I'm Jerry Hesch from the Hesch Institute in Aurora, Colorado, and my client Stephen flew in from Indianapolis. He had a lifting injury to his low back and has been diagnosed as having sacroiliac joint dysfunction and pelvic floor dysfunction. And the area of his body where he feels most of it is along the right lumbosacral, sacroiliac, and along the medial gluteal cleft. He does present with some pelvic asymmetry. It's a little bit higher. Maybe a side view would demonstrate that. His iliac shelf is higher on the right side, and the ischial tuberosity is a little higher on that right side as well. I can spring superiorly through the pelvis. This force translates nicely. When I come inferiorly, he moves nicely on the left, and on the right doesn't move well. And that's because his pelvis is twisted in a manner in which the right side is higher, effectively rotated anteriorly and to the left, and that's the entire pelvis. So that limits inferior glide mobility. The sacrum is symmetrical at the top and at the mid portion, but at the lower portion, the lower quadrant, my right thumb, or his right lower sacral quadrant, is more prominent towards the ceiling. And I can spring him on the left. Force goes right through his whole body. And when I come and try to spring him with the same amount of force, there's no movement on the right side. We name this a sacral torsion. Coming underneath the sacrum, he's lower on this left side. That's lower towards his feet. And when I come under the sacrum and try and spring it, it moves freely. I can see his head bob up and down. So the force translates through the SI and on through the rest of the body. On this side, using the same amount of force, and now I'm actually doubling and tripling the amount of force, it just doesn't move. It's stuck in a side bending pattern. I'm describing a motion deficit. You can't look inside the sacroiliac joint and actually describe the geometry within. And these might be external changes of the posture of the pelvis. But rather than get into the debate of does the SI move, how much does it move, can we detect it clinically or not, what I look at is movement. Does he have this normal spring mobility? Now with this pattern, it's important to evaluate the coccyx, and I think you can see with the camera view that his left side of the coccyx has a deeper sulcus. I can go higher towards his ear on that left side. If I now come inside the sit bone, his right sit bone is very close to the midline crease of the buttocks. The left sit bone is more lateral. There's at least 1.5 inches distance from midline to the medial part of the left ischial tuberosity. Now when I try and spring that ischial tuberosity, that doesn't move. And when I try and spring this one, you can see a tiny little bit of movement, and the motion is taken up quickly. After that, it becomes very rigid, and I'm not able to spring it. Same going in this direction, and same thing going in this direction. And what I found is this pattern, which I call a lower windswept pelvis, oftentimes accompanies the side bent pattern of the coccyx. And so it's important to establish symmetry of the pelvis and symmetry of muscle tone and ligament tone when treating this pattern, especially treating the coccyx. And what I'm going to do now is look at tone in the sacrotuberous ligaments. And you can feel that has a certain density to it, different than muscle. And on the left side, I can indent that ligament a little bit, and that's normal. On the right side, when I try and indent this ligament, it actually feels like bone. But there is no bone in this area. So this is the back of the pelvis. And the sacrotuberous ligament goes from lower sacrum across to the ischial tuberosity, just like an upside down V. And I'm right in here, and there's no bone in that area. Okay? So the malposition of the pelvis has altered the tone of that ligament. And the other ligament I like to check is sacrospinous, which has a more horizontal orientation, going from the sacrum to the spinous process of the ischium. I can indent on the left, and on the right side it's very, very tight. So I'm not able to indent that. Okay? Now, we also find, if we come up to the L5 spinous process, this is S1 of the sacrum, and this would be L5. And if we come on the right side of the spinous process and try and spring it left, there's a definite resistance there. If we come to number 4, you can see there's freedom of movement. And when we come on the left side of the spinous process at 5, there's free and easy movement. And of course at 4 also. So we've demonstrated some of the asymmetry of the pelvis, and more important than how it looks is how it functions. And spring mobility, such as I'm doing on his rib cage, is a property of joints. You should be able to push to a point where it takes up the slack, and then you should be able to induce a further amount of force, and it should bounce. And we demonstrated how that is altered throughout the pelvis, sacrum, ilium, and coccyx as well, and how that also alters tone of the ligaments. So we are going to treat him, and then we'll come back and film his response to treatment. And he's been to multiple therapists, had a lumbar MRI that only showed a small annular tear, had a couple of x-rays. Who else did you see for treatment? Anybody else?
Saw an orthopedic specialist. But he said the same thing. PT or injection is my only options. What else? Pretty much physical therapy. Saw GI as well.
And you also saw a pelvic floor physical therapist.
Yes.
6 visits?
Yes, 6 visits.
Yeah. And they all seem to agree that your sacroiliac joint is involved.
Yes.
But they don't seem to be able to effectively treat it. Is that correct?
Correct. And this all happened February this year.
Yes.
When I got diagnosed.
Yes. And the lifting injury was in January. In December.
In December.
Mid-December.
Mid-December.
And this is now the end of August.
Right. So.
2018.
It's been a while, yeah.
So you found me online and decided to come out this way.
Correct.
Well, let's stop filming here and we'll go ahead and treat it and then film the response to treatment. Thank you.